far, or any patient you've got that you really want us to discuss or anything? Anything like that? Or any questions or anything you want clarification on them?
Good evening, sir.
Yeah, yes, ma'am. Good evening, ma'am.
Please, I would have loved if you have touched the pediatrics, because some of us here are in pediatrics. In fact, I work in pediatrics intensive care units.
Oh,
So I was
that's
so
good.
happy
Yeah.
you said you are going to talk on pediatrics. I don't know why you changed your mind.
Yeah, ideally, I actually changed my mind because of some questions I got personally, like in my DMs, like case study related kind of things, and I just feel like, well, let's have discussion. Let's just make today kind of case study, then we can revise everything we've touched. But I think because ideally I'm not coming up like I've not prepared the slide actually, but it could have been something I could have prepared if I didn't change my night all of a sudden. Um. But I'm sorry, but it's something we can actually look into. I can speak with the organizer and we can do that. We can run that. That's not a problem. I'm sorry about that, but I just feel like let's have discussions. Let's revise everything we have touched because we've really touched a lot of things, and it will want us like just using case study to run through some of those things. But is there anything you'd like us to quickly speak about, or anything, or any conditions, or any patient presentations, difficult patient, or anything you'd like us to quickly talk about?
There is none. I just wanted us to maybe talk about pediatrics generally. Or another
Oh,
thing, if you can drop your number, if you encounter any problem in the process of managing our patients, whether we can reach out to you.
yeah,
I don't know whether it's possible.
Yeah, 100%. Very possible. Yeah. I'm always ready to, I'm always ready to support, to help as much as I can. Yeah, I'll put my number. Of course, I even already have a lot of people doing that, but I will put my number on the page so we can always reach out to each other, share knowledge and everything. Everyone is learning, honestly, and health field is really a very dynamic environment. We need to keep learning. We need to keep reviewing evidences, research works. What are they doing in this facility? What are we doing in our facility? And we look at what has been your outcome with what you've been doing, what has been our outcome with what we've been doing, and we continue to synthesize those things together, and we continue to make the best decision for our patient. But I'm sorry, we just have to go with case study. Yeah. I know Pete Words is a very different entire, and again, you are working in ITU, Pete ITU, really very great. But I will speak with the organizer, I promised, and we can come up. There is this other part again that we've not talked about, which is ventilations, like mechanical ventilation. I really want to come back and talk about it. Like, let's break it down. There are a lot of anxiety, people, ventilators, alarm sounding, ventilator, all these numbers on the ventilators. What are these things? They could really be very scary. But honestly speaking, there is nothing in all of these things. But we look forward to coming back, and break down some of these things. But let's see what we've got today, which is case study. I've come with 10 to 15 questions. We might not be able to finish everything, but let's just see how far we can go, just to use those questions to revise what we have touched so far. All right, so let's get started. So the first one here has talked about, this is a patient. You're asked to see this patient. So they are being admitted for chest infections. At the moment, they are visibly distressed, they are anxious, they are reporting headache, and the nurses on the ward, the medical team, they've been blasting them with oxygen. And unfortunately, this patient, the oxygen, they've been struggling to maintain target sat, and they are now, they are becoming drowsy now. So what do we think about this? It could be in the middle of the night, somebody just give you a call. Yeah, hello, is that physio? Is that the on-call physio? Yeah, we've got a patient. They are on so amount of oxygen. The more we give them oxygen, The more drowsy they are. Now they are, previously they were complaining of headaches, very anxious, and they are still not maintaining their target SAT. So are you coming to see them? So suppose that was the situation, or suppose you are just on the ward, you are the ward physio now, or you are the ITU physio, or the ADU, or whatever now. So, and this is the patient in front of you. So what are we going to be doing? So what are our thoughts? What are our thoughts? So what do we think? This could also be a case of PEDS. This can also happen in PEDS. It can happen in adults. It could be PEDS, it could be adult now. Maybe we just do a bit of mix here. So how do we, so what are our thoughts for this patient? What do we think is going on? Please, I will appreciate our maximum participation. I will really, really appreciate those things. I'll be on the chat, reading what we are putting in the chat. And if you really want, not opening your mic to disturb us, but if you really want to speak, open your mic, look at the questions. And again, there is no right or wrong in the question. There's no right or wrong in the questions or in the answers. It's just clinical reasonings. Oh, why are we thinking like this? Why is it not this? Yeah, somebody is there. Yeah, hello. So what do we think? The patient is visibly fatigued. You can say they are getting tired. They are reporting headaches. They are drowsy. They are just, and they are not maintaining their target SAT. This is all you've got at the moment, or this is what the nurses or the doctor have mentioned to you at the bedside. So what would be your line of thought? Remember what we said yesterday is the way we see patients. The way we see patients, the way we reason things is going to impact on the decision we'll be making for these people. So what do we think? Who is helping us? We need participation. Don't forget, the more we participate, the more we can have a a good time together. The more we can share knowledge, share, have different perspective to these things. It's going to make it robust, robust experience for everyone. So what do we think? Look at it. You don't have to. Yeah, go ahead, ma.
Okay, they said here that the patient has a chest infection. If I come to see this patient, I first of all check the folder in case to be sure the patient is on antibiotics, and they kept on increasing the oxygen, and the patient kept on desaturating. I think maybe there is an obstruction, maybe mucus plug or something like that needs to be cleared by the physiotherapist. I'll look at I'll do a respiratory assessment, system assessment, and probably there may be obstruction, which can be cleared by the physiotherapist.
All right, thank you very much. Nice thoughts, nice line of reasoning, good clinical reasonings. Thank you very much for that. Yeah, it could be, maybe they've got mucus plugging in their chest. Now, it is really, really impacting their VQ matching, and it's really, really making them to be struggling at the moment. Yeah, it could be we going there doing our stuff. Yeah, I meant like checking through their notes as well to look at their background. What has the other team, what have they done? What investigation they've done? What are their line of thought for these patients? How are they planning to support them? Is really, really very important. Yeah, can we have few more? Yeah, few more physios on board. Few more physios. Yeah. Do we think, if you look at the questions, is there anything you would like to clarify? Suppose you are just walking along the corridor on the ward or something, you are just going, and I just meet you, oh, there's a patient, this is on bed 2, and this is, so they are drowsy. We've been giving them oxygen. They are drowsy. They are saying they are reporting they've got headaches and something. So, and they are still not maintaining. Is there any question you would like to ask me? Maybe any clarification you would like to ask or anything? Or do you feel like this information is sufficient to make your decision? Is there anything you'd like to know? Is there anything? Or if you are at the bedside, what are you looking at? What are you aiming at? Like, what do you think? Participation. Yeah, I'm in the box. Drop your comment.
You also have to check the investigations, the X-ray.
Yeah, lovely.
Done for the patient, yes, to know whether is it pneumonia, is it the infection, is it empyema.
Yeah, good stuff. Yeah, lovely. Thank
Sure
you.
of
Yeah,
the
thank you.
diagnosis.
Yeah. We need to know. Yeah, we need to know. Yeah, what have they got? We need to see what they've done. They've done chest strip, possibly. Yeah. If we look at the chest X-ray, what are we seeing on the chest X-ray? Yeah, chest X-ray is also another thing I like to come back to talk about. It's, at least as physio, we need to be able to read chest X-ray. You need to be able to pick out things on the chest X-ray and correlate those things to our physio. And yeah, this, if we see this might be an indication for this. Yeah, it's also I will still come back, come back and to talk about all of these things. Yeah. Thank you very much for that. Chest X-ray really important. Yeah. Let's see. Yeah, airway clearance. That's PT Benjamin. Thank you very much. Airway clearance. Yeah. It's also important for this patient because they might be struggling with secretion retention. Yeah, PT Hamad. Yeah, lovely stuff, big stuff here. Let's read. Could be respiratory failure. Great, perfect. Now we are getting there. Could be respiratory failure. How? Since oxygen, he explained that, let's say, since oxygen saturation remained low despite oxygen supply. Okay, we keep blasting them with oxygen. 20, 40, 20, 35, this, 40, 60. They are still not maintaining their SAT. Do we want to continue to keep blasting them on oxygen blindly? We need to ask ourselves that question. This is a real life scenario here. Do we want to keep blasting them on oxygen? No, something is wrong. We need to investigate. Yeah. Now, PT Ahmad, distressed. Patient is distressed, suggesting their increased work of breathing. Lovely stuff. Let's say mental decline could be a flag. Okay, mental decline. Yeah, this patient could also be linked to, we'll still come back to break that down. Let's see. Again, since they had the increased drowsiness, may suggest CO2 retention. That is the jargon. That is really, really important in this patient. We need to be able to pick up things, patient presentations, the way they are presented. Thank you very much. Really, absolutely genius, PT Ahmad. I love this. Thank you very, very much for that. Yeah, let's see other physios, what they've written as well. Yeah, a lot of answers are now coming through. Thank you, everyone. Keep popping them in. Yeah. PT Chika, the might need CT. Yeah. The might need CT head. Yeah. It could be an option. Yeah, great. Yeah, PT John. PT John. There is like arterial CO2 is rising. Yeah, absolutely correct. The arterial CO2 is rising. If we don't reverse that, if we don't reverse that, in fact, as that need to be treated as a case of emergency. If we don't reverse that, this patient will just be knocked down into a respiratory failure, respiratory coma, and that might be the end of this patient. Something is wrong with this patient. So now you are the bedside. Yeah, can we have a few more opinions before we move to the next one? Before I share my opinion as well, before we move to the next one. So the goal for this question in particular is just to be able to look at your patient, correlate their presentations, even if you don't have some few things like, even if, let's say, for instance, now we are still waiting for the CT chest or chest X-ray, for instance, or maybe they just started running the ABGs, for instance. Look at the patient and start thinking, what have they mentioned to headaches, drowsiness? What is this? This is looking like a kind of narcotic signs. This is looking like, oh, something is wrong somewhere. Why is he having headaches? Why are this patient? They keep blasting this patient in oxygen and they keep desaturating. And the more they blast them in oxygen, the more they become drowsy. What is that? Are we looking at hypoxic drive? Does it mean that the more we blast this patient in oxygen, the more we are knocking down this patient into hypoxic drive? Remember hypoxic drive? Remember, I think I explained those concepts in the past. Remember that concept. This is it happens. You will see it live in some patients. You just blast them. They might be on 2 liter. They are desaturating. 4 liter. They are desaturating. We change the nasal cannula. We pop them on Venturi. We pop them. We go 35, 40, 60. Nothing. What is going on? The oxygen is not their problem. Something else is their problem. We cannot continue to put them. If you put them on 100, no, if you continue to go higher, 40, 60, 80, 100, at the end of 100, where do you go? And again, as you keep going higher up, the problem is, as you keep going up in oxygen, The problem is they will now keep their ventilation will start failing. The pump will start failing. They will start failing. They will start becoming drowsy. You see some of them complaining of headaches. You can start seeing some of them flapping tremors and all of those things. Something is wrong. They are failing. Their respiratory system is failing. If care is not taken, they'll be knocked down into respiratory depression, respiratory arrest, and coma, and that's the end of everything. So look at these patients and figure out. So what do we need immediately? Say to the nurse, we need ABG. You go to their bedside, first line, we need ABG in this patient. We need to check their CO2. Because you've got reasons to check this patient CO2 because of these narcosis signs you can see going on with this patient. You need their ABG. We need their chest X-ray. If you check their chest, now by the time you look at the ABG, you are looking at their CO2. Is the CO2 driving the pH low? CO2 might have been on the high side. Arterial oxygen might not be fine. They might be on type 2 respiratory failure. Remember all these things. So what do they need? What do they need? Again, why you are doing that? Why the medical team or nurses, whatever, they are running the ABGs? Why have they done chest X-ray as well? You are looking at the chest X-ray. See, yeah, is there secretions contributing to that problem? Because we know that if somebody have retained secretion as well, it might make ventilation vacuum mismatch. It might also cause vacuum mismatch. If there is vacuum, means a patient might be struggling to ventilate, even if they are self-ventilating, they might struggle to ventilate well. If that is our issue, we can also now, because of course, again, like what I explained yesterday, somebody have got secretions in the upper airway. Even before we put them on positive pressure or something like that, we need to ensure that the upper airway is patent and everything is all right. Think about these things. What is their GCS at the moment? All these things you are picking at the bedside of this patient. So now, if the ABG comes, once you get the ABG, what are you checking? You check the pH, the CO2, oxygen, and everything. So you are thinking, what do they need? Where do we go from here? What is their ceiling of care? What is their ceiling of care? Because you know that the pump is failing. Their pump is failing already. So they might need something to offload their breathing. They might need to go on NIV. They might need to go on BiPAP. This goes back to what we discussed yesterday. They might need to go on BiPAP to support them because they are failing. So if they go on BiPAP, remember EPAP can support the oxygenation, can split open their airway, and the high PAP through the pressure support can help them to wash out the CO2, to puff out the CO2 that they've retained. They need to go on that. And again, if the pH, just say for instance now, if the CO2 are really like driving the the pH to really go low. Let's say for instance now the pH is now 7.2 something. Oh, this is dangerous. This is really dangerous. Sometimes if they are for full escalation, some of them might just go straight away to ITU. So we need to be able to pick this. You might go to the patient bedside and you find this situation. Just look at it. It might be you prompting the nurses, prompting the doctor to escalate. It might be when you come around, this is when everything, clinical picture of a patient can just change. It might be when you are at their bedside, everything just changed. You might be able to pick up things and share clinical reasoning, speak with the medical team, the consultant, and everything. Oh, they might need to go on this. This is what you are seeing at the bed. This is their ABG, what their ABG are saying. And again, if they need chest support before they go on BiPAP, what do you want to do? Again, think about it. Do you want to go do you want to climb the ladder up, or you want to jump the ladder to the top and come down if need be? Think about those things. For a patient that is fatigued, that are distressed, they are now drowsy. Do you think if I ask them that patient that is fatigued, if I ask them to cough, do you think they might cycle well with ACBT kind of things? Do you think their cough might be strong to clear their airway? Think about those things. It might be me doing something to trigger cough, to help them to clear. It might be me supporting them on those maybe advanced things to support to help them clear their airway. These things, we need some of these things that we discussed in the past. Because patients like this might need us to use the top, the ceiling of our physio, what we got in our physio toolbox to support them. And then we can pop them on NIV, and then from the NIV, CO2 we keep after 30 minutes, thereabout, or 1 hour, depending on where you work. We can run the ABG again, look at the pH, look at the CO2. If we are happy with that, yeah, physio, you're also checking their chest. Is there mucus plugging? Is there evidence again? If you are fine, if they need that physio again, you do your physio with them. And you keep monitoring them like that. So The reason for this, like I mentioned, is you might, in practice, you might find patients like this. Pay attention to what the nurses are telling you. And again, that is why we need not just physio, we need nurses as well to be able to pick things and relate. So that when the doctor, because nurses are always with the patient, when the doctor come around, they can tell them, oh, this is how they've been doing. Since you before you came around. If the physio are with them at the best, oh, this is their presentation, this is their behavior. They should be able to pick this thing and relate and fit to the other team. And when we get this information as well, we should be able to synthesize this information and use that information to make excellent decisions for our patients. If that makes sense, please, does this make sense to us? Do we make any value of this? Quick, so that we can move to another one. Do we make any value from this?
Yes, sir.
All right,
So
thank
please,
you.
excuse me, sir.
Yes, ma'am.
Like if you have a patient and the patient has is retaining a CO2, and you have checked there is no secretion, no mucus plugging, nothing to clear, and the CO2 is still there, retained. So how do you manage such a patient?
Thank you very
Apart
much.
from that secretion, what other thing?
Yeah, thank you very much. Generally speaking, for physio to do stuff, and this is why we need to be ruthless in our assessment. For physio things, before you do stuff with the patient, you are checking what is their respiratory picture. Like, what is, they are unstable at the moment. Is the respiratory status, is it contributing to their level of instability or instability? We look at that. Then again, now how do you know as physio if you need to do stuff? One of them is secretions. It could be sputum retentions. It could be now somebody can be going up on oxygen. Yeah, everybody should be able to do oxygen. Yeah, if there is no, everybody can change oxygen. Then I feel like they need humidification and this thing. But it might not be me even doing hands-on on them. They just be changing the oxygen, or only the oxygen, and I go. If I don't really have to do, if there's no secretion body, if there's no volume loss, I may not really have to do hands-on on them. But generally speaking, the two strongest physio things is sputum retentions and volume loss. Other thing might be work of breathing and thereabout. If just like this, for instance, now if the patient is fatigued, they are tired, there is no secretion, there is no volume loss, what do I want to do? Tentative, generally, it seems like this is not looking like physio. In your note, you put it there, this is not physio amenable. But this is a deteriorating patient. This is a deteriorating patient. You need to be able to make your clinical reasoning count for this patient. Hard to get. Even though you are not doing anything practically, like you are not doing any hands-on things on them. It could be you just speak to the medical team. Oh, this patient, their pump is failing. They need to go on NIV. You document in your notes. No physio, no current physio amenable things, but they need to go on NIV. You have mentioned to them, and they said them. And if you've got the competent physio, do it here. You start them on NIV. You do the inspiratory time. You do the prep. What is the pressure support? Everything. You set them up. You commence it on them. But if we've not got the competency, if in our hospital, if this thing needs to be led by the medical team, just mention this thing to them. There is no current. Sometimes the situation is the medical team will call you. Sometimes it happens live. They will call you. Oh, physio, come and sit. And you get there, you feel like there's nothing I can do here. Because everybody, we need to tick the box that physio has come. Physio has checked them. Medical team this person has come. This person has come to see them. Everybody, before you escalate patient to another cylinder of care, everybody must check them. No, it could be me now checking them and I say, yeah, they just need to go straight away to NIO. If they are for full ceiling, they just need ITU care, nothing more. Let's intubate them. Now, after they've been intubated or after they've gone on NIV, then I can now go back to them again, monitoring them, because now the chance is there that maybe the infection. Don't forget again, this patient is admitted with chest infection. I expect that the medical team, even before you commence NIV or even during the NIV, there will still be medical optimizations. They have to give them antibiotics. They need to support them. If they need steroid, they give them steroid and all of those things. So now it could now be maybe now that they've gone on NIV, they have now started bringing infection in their chest, secretion. They are now starting to retain secretion and all of those things. Then I can now commence my physio. Initially, I may not really necessarily have to do anything with them, but being able to pick up things, look at things and say, yeah, I need to do something with this patient is really, really very important. Did I answer that question, Ma?
Yes, sir. But if the patient is on a mechanical ventilator,
Yeah,
and is still retaining CO2, what do you do? And there is no secretion,
great.
and it's
If the
still on.
patient is, yeah, if the patient is on mechanical ventilator, the chances, don't forget, for instance, now, if patient is on mechanical ventilator, something more, there should be a barrier between the patient and the ventilator. They will have to be on breathing tube, either trachea or ET tube, for instance. Now, don't forget, some of them might, even before initially, they might be intubated. And if you intubate somebody, what does that mean? You have knocked down their cough reflex. You have knocked down their normal respiratory apparatus, which means you might be, some of them initially, they might be sedated, they might be on mandatory mode, they might be on propofol, amphetamine, all those kind of things. So, which means initially, the chance is there that they may, initially, even, let's say, for instance, now they intubate this patient today. Initially, they might not even start having secretion. You may just, but you need to keep them on the caseload, checking regularly. You might just be asking the nurse. You go to the bedside, oh, when you suction, do they cough? Do they cough during suction? Are they coughing on suctioning? If they are coughing on suction and they are not cleaning anything, it's still not physio job. You still know your patient, but you need to keep them. Now, if they are now, it could be maybe when you pass your catheter, maybe they've got inline suction catheter or they've got closed check suction catheter, and you pass your catheter down into their throat, and you feel like, oh, I'm clearing stuff, but they are not coughing. If they are not coughing, again, as physio, you need to think, we need to support them, because that cough is very, very important to you. I may now say, oh, let me start marking them. Do they need cough assist or something like that? So this is, but if, let's say, for instance, now they are on mechanical ventilator, they are retaining CO2, but there is no secretions. Yeah, then we need to work with ventilator parameters. I might need to just adjust their pressure support. It's just like, what do you call it? The NIV I explained yesterday. If you understand the NIV, you may not really have problem with mechanical ventilator. I will just add just few more parameters, and that's it. And I just need to adjust their pressure support, something that look like that IPAP, to blow out CO2, because it is their tidal volume I need to change. I just need to change their tidal volume, and I need to work within the normal range. If they are not neuroprotected, like, don't worry about those things. Don't worry. We'll come back, we'll explain those things. But for now, it might just be me. Forget about the parameters on the ventilator now, but it might just be me just looking at the ventilator and adjusting. Yeah. And if I don't have that competency to do it in my hospital, it might be me speaking to nurse. This ABG is still not okay. Medical, this thing is still, what can we? It could be you prompting. Anybody can prompt anybody. It is, I don't know, anybody can prompt anybody to do some certain things. So if there is no secretion retention, you might not need to escalate your treatment plan or treatment, what do you call it? You might not need to escalate them or any treatment procedure, like any your physio stuff. You might not need to do your physio stuff with them. Might just be, you are okay. Oh, before we put them on NIV. Oh, you escalate to the medical team. Now they are on NIV, or they have gone on mechanical ventilator, something like that. If there's still no physio stuff, we keep checking with them, because we know now they are on breathing tube, their cough reflex might be problematic for them. Some might not even be synchronizing with the ventilator, because now you keep checking with them and see if there is need to do stuff with them. But being ruthless with your assessment, I think, is the most important thing. You're able to know, yeah. See, let me tell you, sometimes they will even call you sometimes to come and see patients that are just, maybe they've got heart failure, something like that, they got fluid in their lungs or something like that. And you say, chest physio. It is your responsibility to go there and say, this is not chest, this is fluid. How do you know? Because this thing can be really very close. And some patients, on top of their fluid, they still have secretions on top of their fluid again. So this thing can be really, really very, very dicey. But being ruthless in assessment, paying attention to things in the notes, paying attention to what the medical team are doing, paying attention to your patient, and thinking for them. Oh, this is fluid. This is not physio amendable stuff. So they just need to put them on diuretic, give them water tablets, furosemide or whatever, they will be fine. Or if they are renal patients, they might just need dialysis, they will be fine or something. So all these things, somebody needs to be able to make those decisions for patients. But generally, if secretion is not present, if lots of volume is not present, those are two strongest physio things when it comes to chest. Those two things are, yeah, other ones like work of breathing, oxygen, everybody can do those things, or respiratory failure, everybody can do those. But the two strongest is secretion and volume loss. If those two things are not there, it might just be general thing. If you have competency to change mechanical parameters, you can do it. If you have competency to start patient on NIV to adjust this thing, you can do it. Yeah. And again, remember, we are not just seeing patients for chest, we are also seeing them for rehab. Let somebody is in IT unit, for instance, there is no concern with chest. Do we want to keep them forever in the bed? It is our job again to commence rehabilitation with them. There is HTT rehab. I'm going to come back to talk about these things. What are you looking at? What are the ventilatory parameters you are looking at? Before you say, yeah, let's start rehabilitation with this patient. You can rehabilitate somebody connected to mechanical ventilator. You can rehabilitate them, sit them out, do your rehabilitation with them. But you need to ensure that the ventilatory parameters, their ventilatory parameters is optimal. Their respiratory parameters are optimal. Their, what is it again? Their cardio hemodynamically, they are stable. Before we say, let's start ETT rehab, let's start trachea rehabilitation. So it is not just for chest. It might be for rehab. Like the other example I mentioned the other time about patient with fluid, if it is ward-based kind of things, they have come in to see them. This patient is in bed, they've got fluid in their lungs. Now, I might not be able to do my normal chest treatment for them. But how you know, once I start rehabilitation with this patient, getting them out, getting them to stand, getting them to mobilize, that will also help in the fluid reabsorption. It's going to also help that. So it is now, if I need to document, I will just say, at the moment, this is not physio amenable, but functionally, this patient might need functional approach to progress their chest. Function. Because you know, when they start walking, and again, there are some patients that you will find on the ward, for instance, they are alert, they are awake. You want to do Yanka with them, you do your ACBT, they are not clearing, but you feel like, what else do I do? I might need to Yanka them, I need to something, but they are not tolerating, they are not letting you passing your catheter. They feel like this is causing discomfort for them. So in that patient, so what do? Do you now leave them in bed? No. Then you might start thinking in your head, oh, okay, this patient is not tolerating suctioning or any invasive approach for their chest. Then again, if they are on low oxygen and I'm happy to get them out, I might use function also to progress their chest. I might also think about, oh, because I know by the time I start building their strength, I start building up their strength, I'm start getting them out, they are standing, they are walking, they are able, all those things. That will also help to build their reserve, to be able to generate strong cough, to clear those things independently, even without me passing catheter down their throat. So this is the way we think. Sometimes you will meet different patient group, and it will now left to be physio and to say, oh, which approach do I want to use? But again, think about it. You might find some patients, they might be on high oxygen and they are weak and they are not tolerating anything, any invasive techniques. And they are not even happy for you to go and converse with them or any other skills that you've got. They are not happy for you. What do? You encourage them, you might get their family, and their oxygen is really high, even on the ward, and they are really very fatigued, they are frail in bed. The chance is there that they might highly deteriorate. What do? We will not stop seeing them, we keep encouraging them, we will meet different patient group, and ideally is highly very discomfort. You know, patient that is awake, for everyone, you are awake and I'm passing catheter, or I'm even putting MPA in your nose, this thing can cause the highly discomfort. That is why sometimes we think about, can we go non-invasive to invasive? But that is not always the case. Sometimes you need to jump those things and start from the top for some patients. So it is not, there is no direct way to it. It's always patient-led. It's case by case. It's patient-led. All right. Did I answer that?
Yes, sir.
All right. Thank you very much. So we'll move away for the first one. I hope we make a lot of value from that. Yeah, somebody has asked in the chat box. So, PT Chika, sorry, sir, for this patient in the case study, what can be done? What can be done? Not limiting it to physio. If I get the question right, this patient is not limiting to physio. It's everybody. Everybody. It's just being able to identify what is the flag, what is the red flag for this patient now, because this patient is already in type 2 respiratory failure by the clinical signs we can see here. Okay, now it is now me thinking about, oh, before we start them, do they need chest clearance? Do they need airway clearance before we? But you have, even before you activate your own treatment, first thing is activate what is the next ceiling. Where do we go from here? This patient will deteriorate. This patient is dying. This is a dying patient. They are going, they are drowsy, they are not even open their eyes now. This is a dying patient. Everybody must be, they need urgent chest X-ray. To see, we need urgent ABG, run their ABG. Let's think about next year. And now, once everybody has agreed they need to go on NIV. As PC, I'm also doing my stuff at the bedside with them. I can social them, I can assist them, and they might go on NIV. And again, after starting them on NIV, we monitor their ABG. Physio is still doing their stuff. Medical optimization continues. Yeah, and we are updating the family accordingly. We are updating the family. Yeah, we should not always leave that part. Not always leaving it out. Update the family, reassure them. Don't give them false hope, but reassure them. And again, before, like we mentioned yesterday, we are starting NIV. There should be a plan. How about if the NIV failed? No, yeah, it might fail. If NIV fail, what's the next thing? Are they for ITU care, or they are not fit to go into ITU? If they are not fit to go in that, what is the plan? They might be for palliation. They might be, well, let's keep trying. Physio trying their best. Medical team are doing their best. Everyone doing their best. Family are coming. They are visiting. They are reassuring their pastor or father. They are doing their stuff. Yeah. So that's how it works. All right, we go to the next one. Okay. So if we look at the next one, this is another one. I hope we can make a lot of value from this as well. 65-year-old lady, they had a fall. They've got high cervical spinal cord injury. I think we have had discussion about spinal cord, so I've decided to pop in something from spinal cord. They have high spinal cord injury, so they've been currently they're becoming unwell, and they are bedbound. They are in bed at the moment, and their oxygen level is also going up. The oxygen level is also going up, 60 to 80, and you have seen in the note, or the team have mentioned to you, that they are just for ward-based setting of care. They are frail because of the comorbidities they've got, or because of their condition, so they cannot go into ITU. So they are not for full escalation, not for intubation and everything, not for bleeding tube. So at the moment, the medical team are thinking there is a concern with PE, pulmonary embolism, and they are waiting for a scan. CTPA, CT pulmonary angiogram, to rule out PE. So what do you think? Suppose somebody have just called you, oh, Don, physio, please go and call physio. Let's call physio. Let's see what physio can do. Okay, physio, you have come now. You are the one leading us, and we are your students now. So you are the one leading us, and this is the situation of another patient. So what do we think? What do we think? What do we think? She has high spinal cord injury. Just look at the question. What other thing? Yeah, hello, sir.
All your problems you are solving, who you are, and all that, and how you are able to replicate this one in the next 1 to 3 years.
So what are we thinking for this patient? 65-year-old, they had a fall, high cervical injury. They are going up on their oxygen level, 60 to 80, and they are just for ward-based. And the medical team, they are concerned with PE, and they are waiting for the scan. So what are we thinking at the moment? What are we thinking at the moment?
Sir, this pulmonary embolism is a red flag. It's me, I won't treat patients.
Okay, thank you very much. Yeah, being able to identify that is really, really very important. Yeah.
I'll wait for the result to come out first.
Okay.
And be sure that it's not pulmonary embolism, because that can kill patients. Yeah.
Perfect. Yeah, that can dislodge, can go into their heart. They might get MI, might go into their brain. Imagine somebody getting stroke on top of high cervical injury. It's going to be very, very terrible. You can get stroke, they can get anything from there, you can die, anything can happen. Yeah, great stuff. That's really good. They will call you, they will say, come and see them. So nobody will, you can only reason, physio can only reason as a physio. Nobody will reason for you. It is the responsibility to look at patient presentation. Look at what you've seen in the notes. Look at how they are presenting and correlate those things together. Okay, yeah. Any other opinion? Any other opinion? What other thing? Why you are thinking of this PE? I'm not doing anything. What other thing are you looking at in the notes? What other thing are you thinking in your head? What other thing? Okay, maybe later on the scan came out and it becomes negative. What other thing do you think? Just let's add flesh to these things. Yeah, PT Chika, possible injury to a phrenic nerve. Yeah, great. This is, I want us to start thinking like that. Yeah, high cervical injury. What does that mean to us as physio? This is how you are the bedside. You should correlate those things. It's not just patient had a stroke. Okay. Oh, you should think, what kind of stroke? What? Yeah, okay. This is this kind of stroke. Okay. How are they presenting? Oh, right arm, upper limb more affected. They seems more weaker. You can even leave their head. In your head, you should start making some things in your head. You start thinking, oh, this is this. Maybe MCA kind of things. Maybe this kind. No, what is kind? This thinking is going to help the way you handle those patients. Yeah, thank you, Tika. This is really very important as well. Somebody have got high cervical injury. What are we making of that? Even if we are treating them, we are not treating them. What are we thinking in our head? Yeah, Tika has mentioned something. Oh, there might be issue with diaphragm. If they've got injury around C5, C6. What do you call it? C3, C4, C4, C5, C6. That's the motor innervations, the innervations to the diaphragm. The diaphragm will be weak, it will be affected. Is this something like that? Have you clarified? You cannot just come to me and say somebody has got cervical injury. I want to know what level. Or somebody has got SCI. If you cannot, it does not, because I need to start thinking in my head, SCI, yeah, okay, what level? We need to know what is the SCI classification in the note. Or have they done that? If it is medical thing, doing that in your, that's fine. But what is that? You want to know. You want to know what other thing? What other thing? Aside from diaphragm, what other thing are we paying attention to? Let's say the injury is at C7 now, for instance. What other things are you looking at? If it is at C6 or C7, let's spare the diaphragm now, for instance. Let's say it is at C7 or C8. Let's spare the diaphragm. What other things? Yeah. Let me see other opinion people have written. Yeah. PT John, do ABG. Yeah. Look at arterial oxygen FiO2 ratio, yeah, PF ratio, that's really brilliant. Thank you for that. Yeah, you want to look at the partial pressure of CO2, yeah, if they are retaining CO2 because respiratory muscles are weak. Yeah, really brilliant stuff. Yeah, thank you, PT John. Yeah, somebody have written another long one. Let me see. Yeah, PT Hamad, do ABC A to E assessment. Thank you very much. High cervical injury. Yeah, you are thinking, oh, is the respiratory muscles being affected? Is it affected? Oh, cervical injury. Oh, see, even if the diaphragm is spared, if they've got injury at C7 or C8, oh, what other things? What comes to your head? It could be like, oh, there might be some affectation to their abdomen. No, abdomen is not being innervated below that. There might be issue with abdomen. And what does that mean to us as physio? How about clearing their airway? If somebody have got weakness in there is impact, or they've got weaknesses at C7, there will be affectation to the abdominal muscles. They are to contract the abdomen, to clear, to generate that expiratory flow. It's going to be impacted. You're thinking, even what is it again? Even some skeletal muscles might be affected, if I'm not mistaken. You don't have to cram these things. Let me make it clear. You don't have to cram these motor kind of things. It's not the treating patient is different from classroom teaching. It is in classroom you have to see 70. You don't have just Google it, or if you cannot Google it, just in fact in our facility, the walls where we work, we should have pictures on all these things. Just print it out, go to the patient side, go and be doing it in their bedside. This does not mean you don't know what you are doing. You don't have to cram motor this thing. What matters is how we think and how we handle patients. That is what really matters. If somebody has got system, I'm thinking, oh, they might be affected, they might be struggling to clear their airway. Okay, that's fine. Oh, their ventilatory pump might be impacted, all these intercostal muscles. You are linking those things. Oh, yeah. PT Hamad has written, oh, DVT risk if they longer in bed. Yeah. Remember those things. Thank you very much. I can see a lot of things written here. Autonomy is different. Remember those things that we talked about in the past. Spinal shock kind of things, autonomic, genic shock. You are thinking about these things. You are thinking that if the injury is above T6, if the injury is, remember those things we have discussed in the past. Go back to those things, and so that when you see patient presenting like this, you are not just thinking like, you are not just thinking muscle strength, range of motion. It's not just strength, it's not just range of motion kind of thing. In fact, you need to get your priority right. Initially, some patients, what they just need from you is not even range of motion in terms of hierarchy of priority. Some patients might just be respiratory support that they need, because if their respiratory support fail, they will die. If they cannot clear the airway again, they are struggling. They cannot generate good cough. They cannot take in good deep breath. They cannot generate expiratory flow. They will retain secretion. They will have chest infections. They will die. Think about those things first of all when you go to see patients. Think about those things. Do we know what is it now? Do we know what their peak of flow is? Do we know that? Even though this patient is not for full escalation, but suppose they are for full escalation, do we know what the FPZ? Have we checked that? Have the nurses, have they done that? We need to know these things. We are not just looking at range of motion. Range of motion is not just your duty. We're also looking at some other things. Hemodynamics, thank you very much. Hemodynamics, risk of pressure. They are making all these things when you are at their bedside. How are they positioned at their bedside? How are they positioned? Are they work of breathing? Are they able to? You are paying attention to their cough. You are paying attention to their breathing. You are looking at their thoracic excursion. You are correlating their level of their injury with everything. You are looking at them holistically. You are looking at your patient holistically, not just not just range of motion, this thing. You are looking from head to toe. Thank you very much, P.T. Ajala. Respiratory muscles, intercostal muscles might be impacted. All these things are really, really very important. And I really appreciate that now we know that supporting them respiratory wise might take priority in some patients, especially if the injury is above T6, because you know the abdomen might be impacted. Even if the diaphragm is spared, the abdomen, how about the abdomen? How about the intercostal muscles? How about every other thing? Beyond range of motion, in acute hospital, that might be your priority first. Then while you are supporting them, might be looking at their range of motion in bed, in pressure support. Let's get them out of bed. Let's look at autonomic dysfunction, autonomic dysreflection, those kind of things. So how do you low blood pressure? How do we support them? Do they need them above knee, touch stocking? Do they need abdo binder? Do they need recliner chair? Do we need to start tilting them up? Think about all these things. And again, for people that are in outpatient, for people that will be in the community later on when the patient go home, if we truly support them in the hospital. So our role in the hospital is, remember what I said that time, is we want to prevent secondary complications. Secondary complication might be chest related, respiratory related, it might be cardiovascular related, it might be range of motion strength related or musculoskeletal related. But we need to get our priority right. What comes first? I cannot leave respiratory. Somebody that have got spinal cord injury, and so what is it? High cervical injury, and I'm not doing anything respiratory wise for them, and I'm focusing on range of motion. What am I doing? What am I doing? And again, gauge your approach, gauge your treatment. Do not fatigue these patients too much. Get whatever you are doing with them. For somebody that have got high cervical injury, if you overdo things, they can even fatigue them. And remember their ability to recover from that fatigue again. We don't want them to go into, what is it now? Go them into respiratory failure, pump weakness, and they are struggling, they are now retaining secretion. Think about all these things you are doing with them. So be progressive in your approach. So think about your patient holistically. Even neuro patient, stroke patient. This is SCI, right? Even stroke patient. They have been admitted, you are seeing them day 1, day 2. Of course, we need to be seeing them not when they are medically optimized. No, not when until they have said now they are fit to leave the hospital. Now, physio will come. You are denying them, because what the standard guidelines say is see them within the the first 24 hours of their admission. That is what guidelines says. You might just need to look at what you want to do with them, look at their presentation and say, oh, do I need to do this? Don't I do this kind of things? So let's get our priority right. Now we know the priority and we know why we are doing those priority. Okay. Now this patient, if you now put everything we have said in the context of this patient, they have PE. They are just for ward-based ceiling of care. Even if I want to do risk versus benefit, have a look at it. If I do risk versus benefit, don't you think the risk is greater than the benefit at the moment? Somebody that has PE, there is no escalation plan again. How about if they deteriorate? Where are they going to go? They cannot go to level 2. They cannot go to level 3. They are just for ward alone. Oh, I would think in my head, I need to wait for that scan. Just like the previous, our first PT said, I need to wait for that scan. Again, have a look at it. Have a look again. Oh, somebody that they are just have a think again. This patient is just for ward-based healing of this patient have got PE. Yeah, this patient have got PE. How about if they just throw the blood clot, just get the touch and it enters their heart and they die? Or how about it just enter their brain and now they get stroke from there? We are thinking about this thing. Oh, then I will say, oh, now the risk is greater than benefit. Then I need to wait for this time. If that makes sense. And this thing must go in your note. This is clinical reasoning. Not just this, I'm not doing. No, this is clinical reasoning. Now, let's say, suppose after the scan now, there's no PE. Oh, I will now think, what do I need to do for this patient? There's no PE. So what do we want to do for them? High spinal cord injury. Before I do anything, I might need to check. I might need to get their airface, pick-off flow to see where are they on that. Some patient might be poorly, some patient might be struggling, and again, this patient might likely to be low on PCOS. Even high cervical injury they've got again, their cough will be low, and again they are going high on oxygen. They are even getting tired. And I need to think again when it comes to my treatment toolbox. I need to also look at my toolbox and decide: do I need to go from below to top, or I need to jump from top? I need to come from top to bottom. Think about these things. And again, this is high cervical injury. You need to get your priority of treatment right and see what you want. Because again, if you overdo, maybe you are doing low-level treatment and you want to work your way, how about if they get tired? Think about that. Oh, I might just say, oh, this is high cervical injury. This patient is already tired. Let me come from top to bottom. What do I want to use? Maybe there's no contraindication. I want to mark them. Abdomap. I want to mark them to support their cough. I want to do everything that can shift secretion from distal airway to the central airway before I sanction them. That is what I'm saying. Think about that. They've got weak cough, so we need to think about what we can do to shift secretion from distal airway to the central airway before we sanction them. We need cough assist. We cannot overrepeat this kind of patient will need cough assist. You might even need to combine cough assist with your mark to support this patient. And you do ABG, you win their what is it now? You win their oxygen down. But at the moment that we've not got cough assist, your top skills might just be marked to augment their cough. Or if we've got what do you call this thing now? Long volume recruitment bag. This bag is also available in our hospital in Nigeria. You can use that to give them big breath. That can also, you are doing that to support their inspiratory flow, right? Now, by the time that switches back to atmospheric pressure, that can also trigger cough. And while you are doing that, somebody can also be marking them as well. And you function them. You do this function, or you do whatever, Yanka or something, whatever you want to do with them. So sometimes you might need to go from top to bottom. This is not patient group that you go to their bedside and you ask them, do deep breathing, do this thing. They are tired already. That might not work well with them. Think about these things. Think about these things. And respiratory support is your priority here. And after my respiratory support, I can now do, okay, let me do range of motion to their leg. Let me do this. Do they need splinting in bed? Do they need anything in bed? We still now start thinking about that. This is acute hospital. Don't forget your role is supporting them. And from there, you can start progressing their sitting, getting them up, looking at cardiovascular, blah, 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 everything. And again, before you even do everything, remember again, have you read their notes? What is the mechanism of their injury? Don't ignore those things and come to their patient bedside. Some patient might need to be on bed rest, maybe because of their, autonomic dysfunction or this thing they've got. Some patient might need to be in bed rest for 6 weeks. Some might be in 8 weeks or something. Read those things, finalize those things. How have they stabilized their injury? Are they for conservative management? Or I'm just speaking generally now. Are they for conservative management? Or have they stabilize the fracture site with any HORIF or whatever they have done? Or is the patient, or do they need any cola or anything or any J. Cola or whatever this thing to stabilize their head in bed? Or have they mentioned in the note that keep them 40 degrees in bed or 10 degrees, whatever thing they have said? Don't just ignore those things and jump to their best and say range of motion to their leg. What are you doing? What are you doing? You might want to, your goal is to help your patient, but you can also complicate them if you don't pay attention to those things. You can't just walk into spinal cord patient and start saying, let's eat them up. What are you doing? Oh my God. Somebody can die from that. So you need to get things right. Somebody can die from there. Think about those things. Go back to SCI. We explained there's some irritation with the catheter, all this dysfunction, dysreflexia. We have to explain those things. How you do gradual progression out of bed. This is acute hospital. When we have now seen that now they have acute, now they are stable acutely. Then we can now say, yeah, let's discharge them from hospital. And before your discharge again from hospital, think about what they need. ADLs. ADL. You shouldn't, as acute physio, you shouldn't discharge patient without thinking about it. Oh, this patient is going home. Where do they live? Did they live upstairs? Did they live downstairs? What is their step access to their house? Do they need wheelchair? Somebody that is leaving the hospital, they got SCI. Let's say lower level SCI now, for instance, is even sparing the respiratory dyspnea thereabout. So what these things are they going to leave? How will they manage at home? Think for them. How would they manage? Have you asked them what kind of toilet have they got? Do they need any? Not just SCI, general patient, general, everybody, stroke, everything in the hospital. Think for them that you know that this thing, now they've got significant impairment. This thing is going to affect them. This thing have changed them. This thing have deformed them a bit. Think about this thing. Think for them. I know, yeah, there is financial constraint to this thing, but at least think for them. Think for them first of all. Oh, who will be helping them at home? What kind of bed have they got at home? Somebody that have got complete injury. Think about this thing again. It's also part of what you are checking it. And is it complete? Is it income? What level? What is their ACI Asia classification? All those things, they are very important. They are going on. Do they need to be on water mattress? Do they need to be on hair mattress? Think for them. How about pressure sore? How are they going to manage these things? We want to prevent this thing as much as possible. And again, be clear with your goal. Be clear. Don't give false hope. What are we aiming at? Will they be for restorative functions, restorative therapy, restorative rehab, or will they be compensative rehab? We need to define these things. We cannot just be doing everything for everybody and be giving family false hope. There's no false hope. We need to be clear. This is why we are physio. We shouldn't be wasting time. Yeah, we can try, but we shouldn't be wasting time on something we know there's uncertainty. So we need those tools to be able to make those decisions. We need those sound clinical reasoning to be able to make those decisions with patients and their family member. And we advise them appropriately. And we think for them, what do they need? The fact that you've got complete injury does not mean that's the end for you. We need to think, what do they need? Do they now need adaptive equipment for them to be able to do ADLs? We need to be able to advise. Yeah, there are psychological things to all of these things as well. Use your ICF classification. Now they have even left the hospital now. They are in the community or in our outpatient facility now. Think about all these things, ICF, break everything down for them. Do they need, some might even need psychology, some might need pastor, they are far to speak to them. And don't give people false hope. This is why we are professional. This is why we are different from every other person. This is how we should be reasoning as physio. There's a whole lot of things, but go back to that SCI stuff. And again, the goal in outpatient is going to be different from the goal in the inpatient facility. The goal in outpatient might be spasticity management kind of thing. And remember what I said about spasticity as well. Spasticity, there is no monopoly to spasticity. Everything is not just spasticity, is not just physio problem alone. I think that is another thing we need to continue to tell ourselves. Spasticity is not just physio problem. It is MDT problem. There is no monopoly to it. It's MDT problem. A lot of things can trigger spasticity. Pain can trigger spasticity. SSO can trigger infection. If it is infection that is making spasticity work, what can physio do for that? No, they need antibiotics. Some might even need injections, botulinum toxins, depending if it is focal spasticity or global spasticity, whatever they are. And again, remember what I said in that SCI kind of things again. What is it? Remember what I said that time. So you just need a whole lot of MDT approach or MDTs kind of things. So it might be standing rehabilitation, retraining. If they are for active rehab, let's retain them. They need cardiovascular endurance to training. They need strength training. They need the outpatient people will be dealing with that. They need clear goals, set clear goals. Their goal will be different from people in the hospital. My whole handling these people in the hospital is preventing secondary complications. I don't want things that are not supposed to be there to come in, to kick in. And my goal is stabilizing the respiratory wise, everything. And also people in the outpatient facility too, they should be able to support if they've got respiratory conditions. It is not my job to come down from acute hospital to be treating that. I know things work differently in Nigeria anyway, but we need to also be thinking about all of these things. Thank you. Any question on that? And do we make any value from that? Yeah, thank you, Pichichika. Patient, we have risk of autonomic dysreflector. Brilliant stuff. Any question on that? Do we make any value of that? Hello? Hello? Hello, are we still there? Oh, if I'm not responding again.
Yes, so we are here.
Oh, okay, all right, thank
Yes,
you.
we can hear you. We can hear you.
All right, thank you very much. Yeah, great. So we'll move to the other question. I think my numberings are not correct. This is the third question, not second one. So this is another one. This question is on tracheostomy. I think at some point we talked about tracheostomy patients as well. So, and I think this question was also part of the first test that we did as well. So I just repeated some of them. So it will be like a kind of revision as well. So this is question on tracheostomy. 65-year-old. Why is everybody 65? 65-year-old, they've got CAP, community acquired pneumonia. Currently now they've got increased work of breathing, dyspnea. So they were admitted because of CAP, community acquired pneumonia. Now they've got work of breathing, dyspnea, secretion burden. That past medical history, they've got tumor in their airway, subglottis tumor. So they had, because of that tumor, they have neck dissection, all those kind of surgeries, and they removed the tumor. So they had emergency tracheostomy since then. So, but previously, before they came in, they are normally independent. So, but at the moment now, they are in the hospital. So they are having, they are on humidified oxygen. So the amount of oxygen is 60%, and the flow is 50 liters, and they've got fenestrated tube. I think I explained, I spent a lot of time on these things as well that time. So you are at their bedside, and nurses have mentioned to you that this patient is distressed, they've got weak cough, they cannot even cough and clear independently, they've been functioning them, and they have continued to desaturate. And the little bit that the nurses have been clearing is just yellow secretions. I know in Nigeria it is the nurses that are doing this functioning. When we go to see patients from chest point, you're also asking them, oh, are they coughing on functioning? You should be not just go and do ACBT or spirometer and just walk away. No, that's not great, I would say. Speak to the nurses first. Before you came, they've been doing something with them. What have they been doing? Most likely, functioning. No, they've been functioning them. You ask them, are they coughing? Cough is very important to you. Oh, okay, you were clearing. Did you, like, in terms of secretion load, how is the secretion? Are they like, is it minimal secretions? Is it moderate? Is it more secretions? You're asking them secretion load. Ask them about viscosity of the secretions. Is it thick? Is it thin? Ask them about color. You can, in your head, you are using all these things to think, oh yeah, oh, because of their chest infection, their CRP is high, their white blood cells is high. Yeah, okay, the color is yellow. Are we looking at infection? And oh, the secretions, if the secretions is thick, you can even advise them. You can advise, you can speak to medical team. Oh, they might need bronchodilation, they might need hypertonic nerves, they might need nebulizers, they might need this, they might need that. If they are, so ask the nurses first of all. Somebody have been doing something before you came in. Don't just go in, do your own and run and go away. No, we are working together. Ask them those things. Ask them those. And it, again, to me, it does not really like make much of sense. I go to patient bedside. I am shifting secretion to their airway. So I need somebody else to come and be clearing those things I'm shifting. And do we think it is all patient that can cough and clear? No. Some patients will call it that their cough will even be gone. Some patients can even, some people might not even be awake. So how do we get them to cough? So, and is it every time? Nurses, they have a lot of, if it is word-based, there might be a lot of patients they need to be attending to. It should be within our own scope of practice as well. to be able to do suctioning, shift your secretion, suction them. I don't need external body to be helping me with that. This is a good skills we are missing out, like in Nigeria. You need to be able to shift. I shift my secretion, I bring it to the eye, but I clear them. I don't need external body to help me with that. If I need help, like maybe they need bronchodilator, they need anything, I will go straight to the medics, prescribe. If I've checked their drugs, it's not prescribed before I came in, prescribe this thing for them. If I exhorted them, see they are whistling, they need bronchodilator, yeah, prescribe it to them. They need humidifier, they need, what is it again? They are on regular nerves. We need to go higher on their nerves. I will tell them, prescribe, nurses, give them. It could be, it could be even me, if they need, like they still need more chest clearance. It could be me just say, okay, now, nurses administer the nerves, I will come back after 15, 20 minutes to continue my physio. So these are great skills. I don't really know, like, these are great skills we are missing on. I don't know how we need training on this now. This need to be part of our scope of practice. It does not make sense. Like, it does not really make sense. You are in the middle of the night, nurses are busy with other patients. Your patient is weak, they've not got cough, you shifted secretion, so you need to wait for that nurse. They finish administering their medications or attending to family or anything before you. It does not make sense. It does not make sense. It does not make sense at all. So this needs to be changed. And changing it means that you and I need to be talking about it. You and I need to think about how we can get training on this, hands-on training, to be able to do indication for suction, the indication, contraindication, not those things, suction catheter, size of suction, all these things, important. All right, let's go to the questions. What further information do you need before your assessment? It could be from the nurses, it could be from the doctor, it could be from the notes, it could be from the patient. So what other information? Anyone you are answering there, I think we've got 5 questions there. Anyone you are answering, just put it in the chat box. Just put one and put your answers there so that it will be more organized. The other ones are, what will be your assessment? What MDT members are you talking with? What are your tracking? Do you think this patient is suitable for weaning at the moment? Do you think they are suitable for trachea weaning at the moment? I think I explained tracheostomy weaning. I explained all those Swedish nose, finger occlusion, trial, cough down, all those things. I think I explained them. I explained them the other time. So this case study are just refreshing our brain on what we have talked about. So anyone you are asking there? Anyone? Anyone helping us with any of them? It could be your assessment. If you want to do assessment for us, just open your mic. Just tell us what you are checking in the assessment. Or if you are speaking with the nurses, what kind of things are you asking the nurses? Or if you are reading the notes, what are you picking in the notes? And if it is last question, difference between fenestrated and non-fenestrated. Suppose I want to function this patient. Now, do I need fenestrated to him? Like the inner tube, does it have to be fenestrated or non-fenestrated? Which of them? I think we have discussed this thing in the past. So ENT wards, head and neck ward, they are also really, really physio domain area. I don't know. So these are areas we need to be going beyond our neuro-orthopedic ward. Beyond neuro-orthopedic. We need to be going to ENT ward, supporting patients, checking their trachea, patient on trachea, laryngectomy, neck dissection patient. This patient needs physio. They need physio. So who is helping us? Any response? Anything? Anyone? Are we still there, please? Hello?
Yes, we are.
All right, thank you. Anyone helping us with the assessment? Okay, let's do assessment. The assessment, how are you assessing them? Is it going to be your A to E assessment generally? Check their airway, check their this, check their that, check their breathing. You've got some breathing stuff here. You've got their on oxygen, they are high on oxygen, 60, the 50 liters on oxygen. What is their work of breathing? Now, nurses have been suctioning them, they've got thick secretion, small amounts. Yeah. You're asking the nurses, have they had neb? When was the last time they have nebulizers? All those kind of things. We know the color of the secretion at the moment. So Great. Maybe the medical team or from the medical note, you are looking at their care of ceiling of care rather. You are looking at their ceiling of care. What if they further deteriorate? Where are they likely to go? Where are they likely to go? Are they likely to go back to ITU? Are they likely to, you are checking all of those things in the note because this patient is also distressed at the moment. And again, you are also at their bedside, you are also checking the size of the trachea they got. Is it size 8? Is it size 7? All those kind of things. What inner tube? You want to remove the inner tube. I think I demonstrated all of these things that time. Go back to those things. Go and check them. What size of the inner tube have they got? Is it fenestrated? Is it non-fenestrated? Even the tube now, is it soiled? Like has it been soiled with secretions? If it is soiled, you want to remove that, clean it, pop in back. If it is fenestrated, put non-fenestrated. You want to function them, see if you can trigger cough. Are they clearly well on your suctioning? Is secretion their problem at the moment? Have you look at their notes. Of course, most likely secretion is their problem. Don't forget, nurses have said the blood secretion. They might need nerves. They might need anything, nebulizers, hypertonic nerves, or anything, whatever they've got. They might need those. Now, think about what physio skills do they need? Do you need to do with them to shift secretions from the distal part of their airway to the central part of their airway and ask them to cough it out or suction them? Think about those things. What do they need to shift those secretions? Think about it. Do they need manual techniques? Do they need manual hyperinflations? Do they need cough assist? Do they need anything they need to shift secretions from their basal part to their proximal part? You are thinking about all these things. And in terms of who you are speaking with or MBT you need, even while you are reading the note, ideally, this is also another profession that is not really developed in Nigeria, like speech and language therapists. So who is doing their job at the moment? Maybe the medical team. Are there documentation around their swallowing all these things, swallowing, dysphagia, all those things? Are there issues around those things? What is going on in their airway? These are something normally we want the speech and language therapist to be doing. Sometimes they might say, oh, we need camera to look, fluoroscopy to look into their airway, to visualize their airway. Speech and language, they do all this, they do all these things. They do all this. But at the moment in Nigeria, it could be medical team doing, but these are professions that need to be developed too. Speech and language, just like physio, we are developing our own. OT need to be developing their skill sets. Speech and language, dietitian, everybody. But I don't know. The governance is just killing other professions and is impacting patients. It's really impacting patients. Okay, so let's just do our bit here and go. So, what those things? So you are looking at everybody's notes you pick. So think about your skills you can use to shift their secretion, and you let them clear, and you start winning oxygen. And while you are doing your stuff, you are reassessing them. Do I need to repeat? Do I need to go again with my cough assist or this thing? And again, some patient might be cough down, and they are distressed. You might want to cough them up before you maybe cough assisting them or MHI or whatever you want to do with them. Go back to those things. Go back to those pictures. I show pictures. I brought a lot of pictures and to explain all of these things. They are really important. They are really, really very important. So I might not be able to touch anything. It's just everything here. It's just I'm just doing it surfacely, but just to let us remember some important things. But go back to those videos and watch them again. ENT world, we need to be going there as physio. We need skill set to be able to handle patients with trachees. And it could be scary again. It could really be scary. Trachea patient, laryngectomy. You even find some of them with attachment, but there is nothing there. Really, there is nothing really there. It's just skill set. It's just familiarizing ourselves with those patients on those wards. That's it. All right, we go to another one. This one is TBI patient. TBI patient. Hello. Is it making sense? It's just
we are here. It's making sense, sir. Okay. We are here.
Thank you very much. All right. Yeah, let me see what people have written. Okay, PT Smiler, thank you. Thank you. Yes, thank you. All right. So this other one here is on TB high. So This is the patient injury. If you look at the screen, let me put this thing. Oh, sorry. Sorry. So let me just what I say now. Okay, we've done this one. So this is the patient injury. So this man this time is not 60, 65. This man is 58. This gentleman is 58. So they've got road traffic collisions. So at the moment, their GCS is 3/15. Please pay attention to their injury, and they are intubated at the moment. 58, road traffic accident or collision, whatever, their GCS is 3/15. So their the injury they've got is left frontal subarachnoid hemorrhage. They've got DA high, diffuse axonal injury. They've got SDH, they've got lung contusions, they've got rib fracture. There's a small flare segment in their ribs, and they've also got right clavicular fracture. Have a look at that before I move away from, before I flip it over. Have a look at this. 58 GCLs of 3, road traffic accident, a whole lot of injury. So that's their injury. Okay. All right. So now they are in the ITU, they are having ICP both, they are monitoring the ICP. Initially, they've got DVT, but they've treated that, that's not a concern. So now they've got chest X-ray. You have looked at the chest X-ray, right lower consolidation. They are on ICP monitor. The ICP at the moment is just 12 to 15, but it's rising, it's spiking to 35. Okay, we also have the ABG here. Okay, if you have a look at this screen as well, have a look at this. Have a look at this. I think we've answered similar question before, but just have a look at this. Have a look. Are we checking through? Hello, are we there? Are we checking it? Hello? Hello, is someone still here? Oh, okay, all right.
Yes.
All right, thank you. Okay. So the question is, what are you, like, you are trying to speak with the nurse now. You are at the bedside now. So what information will you be getting from the nurses? So what handover would you like to get from the nurse? And what is your physio priority for this patient? What are your cautions? And how does the ICP and physio, like how can the ICP impact your physio? Let's look at the question, then we'll go back to, like, let's look at the questions, then we can go back to the clinical picture again. You want to speak to the nurse. What conversation will you be having with the nurses? Okay. In terms of priority for your physio, what will be your priority for this patient? Then what are your cautions? What are you, because of this, I won't do this. What are your cautions for physio? And how do you think ICP will impact your physio? Those are the questions. So let's go back to the clinical picture. This gentleman, 58, GCS of 3/5. We all know what that means. They are unresponsive, so they are intubated, so they need to be in the ITU. Unresponsive patient need to be in the critical care. Okay. So they've got a whole lot of injuries. You can find here left frontal, diffuse axonal injuries. They've got DHH, SDH. They've got lung contusion, rib fracture with small segment, and clavicular fracture as well. Okay. So, again, they've had chest X-ray that is showing right consolidation. The ICP is 12 to 15 and is going to 35. And they have ABG. So if you need to be speaking with the nurse, of course, we want senior physios to see this kind of patients, not just random physios. We need ITU-based physios, like ITU, not musculoskeletal physio, not neuro. Yeah, neurophysios. Neurophysio can see them. Yeah, neurophysios. Because they should even be seen by neurophysios, neuro ITU physios, not general physio, not general neurophysios, no outpatient neurophysio, community neurophysio. So we want we want neurophysio that are skilled, respiratory skilled, to see this kind of patient, because you can't just go to their bedside and be doing anyhow. Because whatever you do to this patient, you can make things worse. And if you don't do your stuff, you can make things will go wrong with this patient. So why do we think if we don't get things right with this patient, they might deteriorate? And if we don't do things for this patient, they might deteriorate. Why do we think that? I think let's start from there. Let's start from there. Can I have some opinion in the chat? Why do we think we need, if we don't do our physio with them, why do we think, okay, if we don't do our physio with them, they might deteriorate? Why? If you don't get your physio right with them, you can even make them worse. Why? Why all these things? Who is helping us? Open mic if you want to speak, if you like to speak, if you want to, yeah, so who is there? Hello.
Okay, so there are a lot of concern concerning this patient.
Okay.
Okay, like you said that the patient has right clavicular fracture.
Okay.
And when a patient when the clavicles, when they are not cleared, you mobilize more than 90 degrees. Okay. Shoulder mobilization should be more than 90. If it's more than 90 degrees, it can the fracture, the clavicle can puncture maybe the vessels nearby. Then the rib fracture also is also a problem. Okay. So if the patient has maybe secretions, the secretions, the return secretion can increase the CO2. Okay. And if the CO2 is increased, it can lead to dilatation of the vessels. And when there's the dilatation of the vessels, it can pump more blood. There'll be more perfusion, cerebral perfusion that can also increase the ICP. Perfect. So the patient, the GCS is 3/15, which is okay, intubated. Yes, of course, the patient must be intubated because of this, because the respiratory muscles are not working because of this. Yes. I don't know. Is there? I think that's all I have for now.
Yeah, thank you very much. Thank you very much.
They also have the lung contusion.
Yeah.
Lung contusion. If you have to be clear, you have to be sure whether the patient has pneumothorax with this lung contusion. Also have to be careful. In fact, the initial stage, I don't think physio can come in because it can lead to pneumothorax. I don't know. That's another thing I have to say about the patient.
Thank you very, very much. Thank you very much. Yeah, absolutely genius. Yeah, really good stuff.
Then another thing you have to do, position the patient, the head, neutral position in 30 degrees.
Yeah.
So another thing you have to do for the patient.
Absolutely. Yeah. 100%, 100%. Perfect. Thank you very much. I love that. I love that. Yeah. This is how we want to be thinking for our patients. This is how we want physios to look at patient and say, wow, let me say, do I really need to do something? Do I really need to do something? This is how we want to just like look at the whole clinical picture and look at it and say, yeah, do I really have to do stuff? I think I'm not happy to do so because of this, this. Yeah. And yeah, and you think, oh, do I really need to do so? Yes, I need to do stuff, but I'm worried with this. Oh, when she was speaking, she spoke about, oh, they need to be cleared for this. We need to, yeah, absolutely. Absolutely. Look at the injury patient have got. Look at what the associated injuries they've had. beyond the head injury, what other thing have they got? You need to clear them one after the other. Oh, they've got, somebody can have head injury and have tibial fracture, fibular fracture, femoral, this thing. Even though that might not be your priority at the moment, that might not be your absolute priority, because somebody with GCS of steel, we're not going to stand them and start working them. No, it's not priority at the moment. But at least clear those things. Even put it in your note. Caution, tibial fracture, this, right lung contusion, rib fracture. These are all cautions for physio. So you need to clear them one after the other. Oh, somebody with associated injury, clavicular fracture, somebody can even have penile fracture, this fracture, all those things. Clear them. Oh, what is the management for the rib fracture? Are they for conservative management? Is there any restriction in range of motion, like you have mentioned? Or somebody with rib fracture. Oh, have they got flesh segment to their ribs? How is it looking like? Is it much? Is it small? In terms of me doing physio with them, I am thinking in my head, how about if I need to do my percussion? How about if I need to do shaking? How about if I need to do expiratory vibes or fibs with this patient? You are thinking, somebody that have got rib displacement, small segment, do you want to go to their best and start jumping on their chest? Do you want to further damage, add to their problem? We don't want to go into that lane. We are thinking like that. This is how we are thinking. Somebody have got lung contusion. Oh, thank you very much once again. Somebody have got lung contusion. I think, oh yeah, how is it? Have they got pneumothorax? If they've got pneumothorax, are they for chest drains? Or they might even say, no, they are not just for conservative management. We are not worried. Fine, if they are not worried, that does not stop it. Even with their pneumothorax, whatever, then I'm not worried as well. If they are not worried, I'm not worried as well. But being able to know that these are cautions and being able to clear those things for your treatment. And again, if you have a look at it, somebody have got clavicular, I'm looking at, in terms of positioning, I need to be careful. In terms of somebody have got rib fracture, that rib fracture, if I need to do I will link that to my treatment with what I've got in my toolbox. I've got rib spring. I've got reef spring, I've got, percussion shaking in as manual technique in my toolbox. I am thinking, can I do that? Can I do that with them? And what side of is it? Is it left? Is it right? This patient I've got right. If I need to do it, maybe on the left. If I need to do it, if there is problem on the left, if I need to do it, maybe on the left, but on the right, can I really do it? I am thinking in that lane. If I need to do positive pressure, advanced things now, maybe am I thinking, that flare ribs, well, not really small flare. I'm not worried. I can do it actually. But again, it might be you talking to your senior. It might be you speaking to maybe consultant in charge, maybe cardiothoracic consultant, and ask them, are they also happy with that? Yeah, but I'm not really worried. It might mean just tracking my maybe negative pressure. If I need to clear them, they need to if the machine we need to swing from positive to negative, that might be some collapse in some part of that flesh segment. I don't want that to control their heart. I'm thinking, what pressure can I put that? What time? These are things I'm reasoning in my head. So I'm linking their injury to what I've got in my toolbox. You look at their injury, you look at your toolbox, and you start thinking, this because of this, I won't do this, because of this, I won't do that. And again, in terms of priority, look at what will be the physio priority. At the moment, is it going to be chest? Is it going to be rehab? Is it going to be range of motion stretching in the bed? So look at your priorities. And again, remember, this is ICP patient. Any small thing you do will tell on their ICP. It's going to tell on their cerebral perfusion pressure. So you want to be careful again with whatever. So you need to be clear as physio. Like I mentioned that. Sometimes it is not enough case that you need to do it. You need to do things with them. And again, you need to be clear. Do I need to do things? Your respiratory assessment comes into place. Your top-notch skills. That was why I mentioned this is kind of patient we don't just want random physio to see them, but skilled physio that are already in seeing this kind of patient group, that are senior physio to see this patient in ITU or neuro stroke, neuro ITU with respiratory skills. Now we want to see this patient. We want them to see this patient. What other things are you thinking about for this patient? Remember again, have you checked the medical note? This patient likely to be on, I mentioned ICP protocol that time. You want to ask the medical team, like she mentioned about CO2. If you remember CO2, like she explained, CO2 can also worsen the patient ICP. Remember, I think I explained the concept the other day about Morokeli doctrine, if you can remember, that in the brain is our skull is a rigid structure. Inside the skull, now what have you got? You've got the brain cell, you've got the blood, you've got the CSF. And all these three things are in constant equilibrium. They keep moving in they are just in constant equilibrium in the brain. If somebody have got tumor, for instance, in the brain now, somebody have got tumor or bleeding in the brain. So the skull cannot expand, but two structures are there to try and compensate, like CSF, blood drainage, venous drainage, they will try to compensate. But at some point, if the tumor keep getting larger, or if the bleeding keep getting, if the patient continue to bleed in their brain, what is going to happen? So the compensations can fail. And if that fail, pressure will keep rising in the brain. And if pressure keep rising, brain cell can innate down into the foramen magnum. We don't want that. So you have also checked the medical notes. See, oh, okay. Some people might even have decompression surgery, some to decompression cranectomy. All those things you have checked to see what they have done for them, because you really understand how to manage patients on ICP. So for the ICP protocol, they want their CO2 to be really, really well controlled. Because if CO2, if CO2 continue to rise, or if CO2 gets rising, CO2 is a vasodilator, like she has explained. It's going to vasodilate the cerebral fluid, and ICP will keep rising. You don't want that. And again, how does this thing relate to physio? Is related to physio from secretion point of view. The patient has got secretion retention. If patient has got secretion retention, they will not sink. The ventilator will not sink well. They might not be ventilated well. If they are not ventilated well, there might be issue with their tidal volume to blow out CO2. Before you know, they will start retaining CO2. And what does that mean to our patient? ICP will start rising up. Their brain pressure will start rising. We don't want that to happen to our patient. So think about it. Check what is the target CO2 that the medical team have set for this patient. They might say between 4.0 to 4.5, something like that. Look, have they set any cerebral perfusion pressure? This patient will generally be on monitor in the ITU. They will be on monitor. You are looking at their live, ideally. You should be looking at their live ICP, looking at their cerebral perfusion pressure. What have they said? Is it 55 to 70? This thing should be documented. If they've not documented, you want to speak to them, because you are doing your physio in reference to this, and you are looking at the screen. This thing is important. Sometimes you might find mean arterial pressure, all these things. And again, remember how your mean arterial pressure, your blood pressure, how is also linked to your ICP. That means before I also treat this patient again, I am also looking at what is their blood pressure. What is their blood pressure? What is their mean arterial pressure? All these things, I'm looking at it. Because I know whatever I'm doing, let's say I want to give them positive pressure now, for instance. If I inflate their chest, intrathoracic pressure will rise up. If intrathoracic pressure rise up, the cardiac output will reduce, the venous will turn back to the will be poor. That can impact on the cerebral perfusion pressure. Because this kind of patient, we want their brain to be well perfused. We are thinking like that. What is that? All those things. You are looking at them from hemodynamic point of view. Are they stable? You are looking at them. Do I really need to do physio? Have a look at them and say, yeah, is their problem respiratory issue? That is the first question. Is their problem respiratory issue? That is because what you are coming to treat with them is respiratory problem. You are not treating anything cardiac with them. It's respiratory problem. Is their problem respiratory problem? Then again, is their problem something I can fix from respiratory point of view? How do you know? Is their problem secretion issues of volume loss? This is what you can treat. You are asking yourself these questions. And how do you know? You assess them, you auscultate them, you look at their chest X-ray, you look at their blood, their lab, what is their CRP, white blood, all those kind of, what are they saying? You correlate all these things together. You auscultate, be good with your assessment, you palpate them and see and find out what can you feel, what can you hear. These things are important before you say you want to do anything with them. And again, the ICP protocol, she also mentioned positioning in bed. Somebody that has brain bleed because of head injury. We don't want to keep them down. We want them nice and upright in bed, maybe 30 degrees in bed, like she mentioned. Why? We don't want pillows or anything to be crushing in their neck, to be compressing. Even if they've got collar at the moment to stabilize that, we don't want that collar or whatever to be compressed on their jugular vein that is returning blood back into their right atrium, or their carotid artery or anything. Because even those anything compressing, all these things, compressions or anything compressing on their veins or their artery can also worsen the ICP. That might even be the case of some patients that you just go and just readjust their collar and the ICP will be fine. Think about all these things. And think about your physio as well. Because I know if I do percussion, the ICP can just rise up and come back again. If I do shaking, if I do cough assist, if I do suction, if I do, so then how will I then treat this patient? That is why you need to be clear. Do I need to treat them? Yes. I need to do myself with them. If I don't have to treat them, no, there is no physio amenable conditions and this thing. And again, the hemodynamic that I mentioned the other time, have a look at their beds. Are they on infusions to support their blood pressure? If they are on infusion, metramine, all this adrenaline, all those things. Have you spoke to the medical team before you do your stuff? Because you can do your physio with them and their blood pressure will just drop. How about if they are currently on ceiling of that drug, those infusion, where do they go from there? And the ICP, and anything that drops their blood pressure will affect their cerebral perfusion pressure. You have made the situation worse. So where do they go from there? Think about that. What is the ceiling at the moment? What is the ceiling? Oh, okay, they are on metramine, this and that, and you have spoke with the doctor or the nurse, the consultant. Oh, if I do physio, their blood pressure drop, because some physio, your physio can also drop their blood pressure, and the blood pressure can impact on the ICP. So if I do my physio and their blood pressure drops, and do you have anything to support it? Yeah, some people say, yeah, I have fluid. Don't worry, I have fluid in my toolbox as well. I will give them fluid. Crack on, physio, crack on. And yeah, you are good. You are good to go. So think about what you want to do again with them. Because again, there is a target for CO2. There is a target for CO2 that you've got, that you are working with. I don't want to do things that will, why I'm helping them to clear chest, things that will make them to lose a lot of CO2. I don't want that, because if they look for a lot of CO2, let's say they just hyperventilate now, for instance, through any of these things that I'm using, that can also bring the CO2 down. But there is a target that we are working with. And again, at the same time, I don't also want to do things that will drop their blood pressure. But again, all of these things that I'm doing with them, they are likely to impact these things. But how do I go? I need to grade it. I need to grade all these things that I will be doing with them. That is why I say these are very, very critical patients, and only seniors that are well experienced can handle them well. Now, that does not mean junior cannot do. Yeah, your seniors are there, they are supporting you, are well trained. Yeah, you can do it. But just skilled physios. Yeah, I can see them. All right. So some other things again is in terms of what are you asking the nurses? If you look at the question here, one thing is very sensitive. The ICP normally is 12 to 15, but maybe when they roll them, when they put them in supine position, when they do suction, the ICP just jumped to 35. That is an indication before you do your physio. You are the best before you do your physio. Now I want to treat them now. Before I treat them, I will ask the nurse, how are they when you roll them normally? When you suction them, how are they normally? Is their ICP stable? Or is it normal? Does it spike up? If it's spike up, what value does it go? And does it, is it transient spiking? Is it transient? Or does it just stay there for like 20 minutes, 30 minutes, or it does not even come back? Or do you need to even bolus their sedation? Or some patients might even need to be sedated. Do you need to bolus their sedation or increase their paralytic agent before that thing jumps down again? Think about those things. You ask them those questions, first of all, before you treat them. Because somebody has been seeing them before you. Ask them in terms of handling, like how are they to suction, how are they to roll in. So that thing can also guide you when it comes to you treating them as well. I don't know if these things are making sense. Is it making sense, guys? Hello?
So it's making sense, but just like I said the other time, the problem we have is that we don't have a ICP monitor.
So
it's a very big problem, a challenge to us here.
yeah,
I don't know. We'll go by the clinical features of raised ICP. I don't know.
So what if they are now sedated?
Sometimes,
What if they are sedated, they are ventilated, and so what do we do? What do we do? What do we do?
no, we look at the Cushing triad. If the BP is high, there is irregular respiration, and there is bradycardia. We see that the ICP is high. But if the patient is chesty, and this Cushing triad is high, so what do you do? If the patient there is secretion and the patient has all these Cushing triad, they are all present, what do you do?
That is it. Honestly, that is why I asked that question. See, Cushing triad, looking at the bradycardia and all those things, yeah, they are great. They are good clinical signs, but in real life, like if you really want to treat them for chest, I might need that real life. I might need that ICP monitor to monitor them.
Exactly, it's very important.
It's important. So from confidence point of view, even me as a physician, I'll be like, oh, I don't want to do things. I don't want to kill human beings. So, but at the same time, well, what I would just say is we just cast our eye on the blood pressure, heart rate, all those things. Yeah, but we know that something is missing. We should just know that something is still missing. And what is that? That ICP monitor is still missing. That cerebral perfusion pressure monitoring is still missing. But because sometimes the blood pressure might even be stable, it might just be ICP just going because of maybe it's not beyond what is it again? Like I mentioned, positioning, shaking patient, all those things, patient being agitated can also make the ICP to be going up, all those kind of things. But what I would just say is if we need to treat them, we should grade whatever thing we know or whatever thing we want to do with them, and we monitor their blood pressure and everything. Then look at all those Cushing triad and all those things. But ideally, it is also a gap that we need to also start thinking about our hospital management, our CMD, everybody talking to the government. Tinubu does not know these things. I know Tinubu does not know that we need this in the hospital. It's responsibility of we healthcare professionals to say, yeah, we need these things. And everybody unanimously we want to start speaking and advocating to our government to fund all of these things. Yeah. So we will just do our bit as physio, look at what we got at the moment, look at every other thing, and we'll just adjust our treatment.
Another problem is that this cerebral perfusion pressure, they measure okay, because you can also calculate the ICP using that and map. Yeah. But the instrument is not also there. So we just based this thing on just the clinical features. So it's a very big problem. It's a very big challenge to us here. Because now you don't know when to come in and when not to come in, whether the ICP is so high that you are not supposed to come in as a physiotherapist, or just leave the patient in low position very well, make sure there is nothing a hindering venous return and all those things. So that's just the thing, sir.
Yeah, thank you for bringing that up. Honestly, it's really a big challenge because I want to treat patients. I don't really know what the ICP is really saying. But ideally, just like we mentioned, we want the ICP to be less than 20 generally. And at their bedside, an ICP might even be like 30, 20, 35. Because I'm just assuming, imagine ICP is just like 20, 25, or before I even start my physio. So how will they be when I'm doing my physio? Just like if I'm doing anything, it's just in my head, I should have it at the back of my mind that I'm just doing it. It's just like I don't have access to real life, to see what is going on in their head, which is bad. So there is no excuse for us at this age that we are in Nigeria. There is no excuse. Is it money we will say we don't have? So there is no excuse that somebody can give for these things. It is just we still not there yet. That is just it. We are still not there yet. We're still not there because we want those real life, what do you call it now? That live monitoring. To be able to say, yeah, I'm doing well. No, I need to stop. no, I need to do this and all those things. But at the same time, from physio perspective, we just gauge whatever we want to do with them, and maybe and again, because if we are not even treating them, it might even like if we are not even treating them, it might even make some of them to even spend a lot of time being sedated. Because one of these things we also find,
Abi, you are not
for long period of time, they will put them on mandatory modes of ventilator and this thing. And we know the implication of keeping somebody to not be awake for a long period of time. This thing on his own, because they are not clearing their chest, they are not coughing naturally. So this is also like putting them at risk of secretion retention. But we just work with what we are. I don't know. God will help us. All right, let's continue. Hope we make value from that. Let's go to another one. Let's come back to surgical wards now. So we've gone to ITU, we've got to ENT ward. Which other thing have we done? We've been to ENT ward, we've been to ITU. Now let's do what do you call it now? Let's come to surgical wards now, general surgical wards. So this is a patient, gentleman, 50 years, day 2 post laparotomy patient, anterior recession. 2 months ago, they've got some abdominal pain, issue with bowel movements. So they were admitted with emergency surgery. That was 2 years ago, 2 months ago. So, but generally, past medical history, COPD, diabetes, mellitus. They live with their wife. They are retired. They are normally independent with AD health. Unfortunately, they smoke. They smoke cigarettes. Okay. So the nurses have mentioned to you that this morning they are desaturating. Their cough is sounding wet. They cannot even clear their airway independently, and they have not been out of bed. They are currently on 4 liters, 87 by SAT, and the respiratory rate is 12. Look at their chest X-ray, basal collapse, right basal collapse, and they are on metformin 3 mils. I will leave this for a while so that we can have a look at the patient clinical picture again. They are 50 years, day 2 post laparotomy patient, anterior resection, end-to-end anastomosis. Great, the surgeons have done their part. Past medical history, COPD, diabetes mellitus. They live alone, normally independent in ADL. They smoke cigarettes. Acute desaturating. When you are at their bed, the nurses, this is the medical team or the nurses giving you handover now. Oh, they've been desaturating. Yeah, their cough is even standing wet. Oh, this man has not been out of bed. They are on 4 liters, 87, respiratory rate of 12, and they've got right basal collapse, and they are on metformin infusion. So how do we, if we look at this first, okay, have a look at that. So now this is the question: are they adequately oxygenated? What factor do you consider? What are the physio problem in this patient? If we don't treat them as physio, if we don't see them, or maybe we are not picking them up to be seeing them by ourselves, or nobody has invited physio to come and see them, what are the likely respiratory compromise they might develop? And what do we have in our toolbox to manage them? What do we have in our toolbox to manage them? Is their oxygen okay? What are their problems at the moment? If we don't treat them, what are the likely things that might happen to them? And what are your toolbox? What do you have in your toolbox? Okay. So this is a gentleman on surgical.
How many liters of oxygen?
Okay, let's go back to it. 4 liters.
Okay, 4 liters.
Yeah.
Okay, maybe you progress to the next level of oxygen delivery. That is from nasal bronch to facial mask.
Yeah. Good. Thank you very much for that. Any other thing?
Is still desaturating at 87%. I think you should go higher.
Okay.
so that I can increase the oxygen.
All right. Thank you very much. Any other thing from the caseloads? Looking like we can use that thing that we discussed yesterday as well, like look at their respiratory capacity before they came in, look at the load they've got on top of that now. Anything we can link up in this patient? What are their problem at the moment? Look at, like, link everything up. Look, let me say this. The way I see patient normally, I look at what is their capacity. Capacity, I think about their past medical history. Then I now look at what is the load, what is the current problem they've got on top of their capacity. Some people can have good respiratory capacity, like little or no significant past medical history, respiratory past medical history. Then what have they got? What is the load? And some people can be poorly. And what is the load they've got on top of that? So is there any link, anything we can relate together? Anything? What is their current problem? What are we seeing them for?
And the patient also has COPD.
Okay.
COPD. So already had a respiratory condition. So at least you also have to know the target SAT from the physician, because it may be less than the 95 that is normal because of that COPD. So that will form your target. The patient has the right basal collapse. If you have to pump in air.
Okay.
And also, when the oxygen comes up after progressing to the next oxygen delivery method, you can now start mobilizing the patient. I think it will also help. Maybe sitting the patient up.
Yeah.
I think it can help.
Yeah, thank you very much. Yeah, being able to look at their respiratory background, COPD. Oh yeah, COPD. Then that might say, yeah, that might prompt us to know what is their target SAT. We cannot just say somebody is desaturating without knowing their target SAT. What if they are on scale 2 and maybe just imagine their target SAT is now 92? Are we going to say they are desaturating? Because we know if we go high up on their oxygen, that can even worsen their problem. So we need to know their target SAT. This patient is coming from COPD background, poor respiratory background, maybe, and again, they smoke. Begin to link this thing up. Oh, they smoke. Oh, they are coming, they've got COPD, you got one kind of condition, they've got link whatever their past medical history is. Look at their capacity, initial capacity. Do they normally have respiratory impairment issues? Okay, on top of that, now what have they got? On top of those things that this patient have got, chronic smoker, COPD. On top of that, now they've got surgery. They've done an abdominal operations. They've had an operation now. And how can that make things worse? Oh, because of that. Initially, even before they came in, were they normally struggle with secretions? These are questions we are asking ourselves. Were they normally struggle with secretions? Were they normally struggle with shortness, short of breath? Or were they normally short of breath? All those kind of, were they normally breathless? This kind of question we are asking ourselves. How did they normally manage if they have all those respiratory issues before they came into the hospital? We're asking those questions because this is their baseline. We need to understand their baseline so that we know that, oh, this is their capacity and this is the problem they've got on top of that capacity. I don't know if that makes sense. So we are thinking in that lane. Okay, now I'm at their bedside. Somebody had mentioned to me that they are wet sounding cough. While I'm at their bedside, I'm also trying to, if they are coughing, some people will just cough spontaneously. I pay attention to that cough. What is the strength? Are they clearing? Are they able to, did they void anything? Did they expectorate anything? I'm paying attention to those things while I'm at their bedside. Now, in terms of oxygen, now, this patient is not saturating. If it is on scale 2, for instance, now, they might say scale 2 is 88 to 92, 87. Okay, what do we do with the oxygen? So nasal cannula, we don't want to go more above 4 nasal cannula. Oh, like you mentioned, we might want to go by face mask, maybe Venturi or simple face mask, depending on whatever is available in your clinic. But again, now remember, we are going higher on the oxygen. This patient have got evidence of secretion body. Do you want to give them dry oxygen? We're also thinking like that. Oh, will it be dry? No, I don't really want dry. I want something that will moisturize their airway. Are they on nerves at the moment? I'm thinking. Okay, I go to their bedside. Don't forget they've got right-sided collapse now. What am I thinking about? Right-sided collapse. Oh, what do I need to do for them now? Do your pain assessment. They might be struggling with pain at the moment. Is the pain optimized? You are thinking. Somebody that have operation, they might be struggling. It might be you speaking to the nurse, give them PRNP medication, give them this, give them that. You might be struggling with pain at the moment. What other thing are you looking at? This patient has not been out of bed. Okay. How are they even positioned before that? How are they positioning in bed? What is their position in bed? Are they slumped in bed? You can find patients groaning in pain, they are slumped in bed and they are high on oxygen or something. Do you want to get them upright? That's even the first thing. From compassionate point of view, reassure them and get them upright in bed, first of all. Again, our hospital bed again is another thing. And that might even be another issue again. But think about what you can do with pillow, get family to bring pillow, everything. But again, there is no excuse for these things. By now, we cannot get standard hospital bed in our facility. There is no excuse. This thing is embarrassing. It's highly embarrassing. And again, I will say this can also be role of physio in acute hospital. Manner handling, speak with the VC and everybody. This thing is not comfortable for physio. It's not even comfortable for the staff. Our best should be able to be reclining, going up and down, to do our physio stuff with them. All those kind of things. Think about patients we are supporting as well. Patients that we need to get into 30 degrees, 60 degrees in bed, sit them up in bed. We cannot do that because we are limited. We are limited. Because we know, like I used to say, if somebody is standing from respiratory parameter, but don't think like that for SCI patients. They are different group. I think I mentioned when I was talking about SCI too. Generally, for other patients, the patient is standing. If there is no contract, the patient is standing. It's going to help their FRC. It's going to help their lung volume. If they are somebody standing is better than somebody sitting. Somebody sitting is better than somebody lying down. This is how we think as respiratory physio. This patient has not been out of bed. I know not being out of bed again can make things go worse for them. How about pain? Not being able to take in deep breath because of the pain. Some patients might even avoid taking in deep breath because of pain. What can we do? What can you do? Do they need reassurance pain medication, supported deep breathing, supported cough, in bed, give them towel, give them everything? Think about these things. First of all, before you, I mean, this can be one of those patients where you think, let's climb up the ladder. Let's climb the ladder up. No, let's do deep breathing. Give them towel in bed, deep breathing through the nose, ACBT kind of things. Let them cough. If they are now struggling, I say, okay, let's try Yanka, let's try this. But if they are manageable with that, and think about getting them out of bed as quick as possible. Getting them out of bed. But look at how they are presenting, because now they are going higher on oxygen. Think about how they are presenting. Marry their oxygen, not just numbers and oxygen. Marry their oxygen. Somebody can be on 60 and still be awake and alert and this thing. But somebody can be on 2 liters and be drowsy. So marry their oxygen requirement with how they are presenting. And think about getting them out of bed. Get chair at the bedside, get them out of bed. Assistance of 2, and document all this assistance of whatever you want to use. Get them out of bed, get them to sit in the chair. Okay, get them to do deep breathing in the chair. Get them to do deep breathing in the chair, those kind of things. Get them to do ACBT kind of things in the chair. Go back in the afternoon, stand them with the frame or assistance stuff too, spot matching, deep breathing if they are able. Yeah, on oxygen. Get them to do all of those things, progress their mobility. Really important. They might not really, and again, for somebody, and again, some people can really be poorly again that we might need to start thinking, oh yeah, I need to go top, I need to look at my top skills. Maybe where is their surgery? Look at their surgery. If you need to go positive pressure, look at their surgery. Well, your anterior dissection, I'm not really worried. If I want to do positive pressure, I can do positive pressure. You can need to them. I'm not worried. I'm only worried with upper, what is it now? With upper injury around upper airway or injury around like all this superjectomy or something. I'm not really worried. Anterior recessions is surgeries around sigmoid column kind of thing, so I'm not really worried. It's really far away from the airway, so I'm not worried. Some people you might need to also support some people on that. So think about that. Again, don't forget Metramino. Yeah, that's another thing. You are the best side. Look at the infusion they've got at the moment as well. No, Metramino 3 means. Okay, how about if you see them edge of bed and their blood pressure suddenly drop and they want to collapse, think about that. Have you spoken to the nursing staff? Is there any ceiling? And then generally 3 means, generally I would say 3.5, less than 3.5, less than 3 is fine. Anyway, you can still do your study. But think about their blood pressure first of all. Before you even, if you need to sit them up, get their blood pressure, their reading. When you sit them up, get their blood pressure again, get feedback from them. And again, it's normal on surgical ward. The patient after the operation, they tell you they are feeling sick, they want to vomit. So don't be panic. Yeah, give them sick food, let them vomit. Get them out of bed if they are able. Get them to do deep breathing in bed. Tell them to do hourly deep breathing and cough. All those kind of things. Stand them, mobilize them to increase their tidal volume, their functional residual capacity, their minute volume. All these things are really important for this kind of patient group. Because of time, we have explained loads and loads of things around managing surgical patients. My word, going back to those videos. Going back to those videos and watch them again to get. So we just do one more and we'll stop here. Just one more. I really want us to talk about this cardiothoracic patient as well. You are on call in the middle of the night, 1 a.m. You got a call that you got a day 1 post right pneumonectomy and thoracotomy patient. The current concern is what they mentioned to you on phone is, oh, they've got increased oxygen, 60% FiO2. They are standing chesty and reduced air entry to their lungs. They are currently on chest drains, and they've got worsening respiratory status. The question is, to the person handing over to you on phone, what other information will you be asking the person? And what do you see as a caution for physio in the patient? And what will be your treatment? Let me go back to it again. 1 a.m., day 1, they just had a new surgery to their lungs, pneumonectomy, thoracotomy, they are on chest drains, their oxygen is going up, and they are sounding chesty, and they've got reduced air entry into their chest. So how do you manage them? So what do you think? Let's take this last one and we'll go. So what do we think? Pop the response in the chat box. Hello, are we still here? Hello, let's take this last one and we'll go. Let's take this last one. Are we still here? Hello? Okay. So let's take this last one. So what are your questions for these patients? And what are you asking? What further things are you clarifying on phone? With the nurses on phone or something? So in terms of your question, like I mentioned when I was talking about positive pressure kind of things, or somebody have got a new surgery to their chest. Think about it. If I need to do manual skills, will I be able to do that? You are linking those things up. In terms of giving somebody positive pressure, they've removed some part of their lobes or lungs or something. If you give them positive pressure, do you want to just blast them here and destroy dismantle the good work the surgeon has done? No, you are thinking in your head, oh, okay, when I come around to see them, I need to speak with somebody. I need to speak to the surgeon that did this operation for them. If they are happy for me to do certain things with this patient, like positive pressure, that kind of things. Okay? To the nurses calling you on phone, You are asking them, oh, have you asked them to cough and have you asked them to cough? How is their cough? Have you give them nerves? How are they positioned in bed? All this kind of, and for the pneumonectomy patient again, your position is also very, very vital to them. Do you want to put for instance, now this patient that have got right pneumonectomy, how do you want to progress? How do you want to position them? Just imagine you've gone 2 lobes now, right pneumonectomy. Do you want to put the right lobes on? Do you want to put the operated lobe, operated lungs? Do you want to put that one on? You put it on. That will be draining and be, gravity will drain. There will still be fluids, effusion, and what do you call it now? Like fluids in the operated lungs. If you put that lungs up, that fluid will be draining to the unaffected lungs. So you need to think about the positioning as well. Think about all of these things. How are they positioning? Any contraindication, anything before you do your physio? The bronchodilate, if they need, how are they sounding? Have they been seen by the medical team? Have they reviewed them before you come in? These are things we are checking. Have they had ABGs? Have they had recent chest X-ray that suggests, that to complement whatever our assessment is at the bedside? Have they had those things? You are checking. And when you come around, they've got chest drains. Why do they have chest drains? Is it pneumothorax? Is it pleural effusion? All those kind of things. You want to know those things before you treat this patient. Because if you need to escalate them on things like positive pressure or all those kind of things, you might need to know. Oh yeah, pneumothorax. Oh, they are on chest drains now. We are not worried. Let's blast them on positive pressure. All those kind of things. I need to use it. So it's still normal, your physio treatment, but what this thing is actually testing is cautions with the patient. And who do you want to speak with? Who do you want to speak with? I don't expect, for instance, let's say they've got any other, let's say they've had trauma, knee issues, blah, 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 or something. I don't want to, and that knee issues have been treated by maybe they are under trauma, orthopedic team for that one. I don't want to be speaking with orthopedic team regarding their lobectomy or thoracotomy they've got. I need to speak with the surgeon, the surgeon that did that surgeon that did that pneumonectomy is the one I want to speak with, not the other team. So think about who do you want to speak with as well. All these kind of things are really important. Not getting validation from the wrong person, get the validation from the right person. That is what I'm saying. All these kind of things are really, really very important. I think I'm tired already, but time has gone, so I think we've been able
to ask the question.
Yeah.
Okay, this one is day 1 post-op, maybe pneumonectomy or thoracotomy. Okay, and the patient is chesty. You can't do the manual chest technique for this patient because it will affect the surgery. So what do you use to remove the secretions now?
Now, to shift the secretions now. So don't forget, this is right side. If there is need for me to, though the problem is on the right side as well, but I'm also thinking about, okay, now it is their cough that is weak. Can I mark them? Maybe. Can I get them into upright position in bed? Okay. Can they, and again, I also want to think about suctioning, can be some of those things we can do with them. Again, I also want to think about, this kind of patients, they might need positive pressure. And again, that is also another thing that I know that is missing our toolbox in Nigeria. They might also need positive pressure. So our toolbox is still not, some items are still missing there. But this is one of the patients, I think I've said it in the past. You can have patients that will have injury to their thorax, injury to their abdomen. You cannot do manual squeeze. Even if you want to do abdominal marks, you cannot do it with them. So where do you go? Do you just leave them? You cannot leave them. You think about what other thing do I have in my toolbox? Another thing could be that positive pressure. And again, if let's say now they now have, if somebody have injury to their chest, or they have surgery in their chest, they have surgery in the abdomen, they have pneumothorax. So all of my toolbox has been rendered useless. So what else do I do? And they are going up in oxygen. There is evidence of secretion burden. So what do I do? Then again, we need to think about risks versus benefits. Then we now think about risk versus benefit. Then I just look at my toolbox. Okay, manual skills. If I do manual skills, if I do percussion shaking, what will that? How will that impact them? As opposed to me doing mark in the abdomen, or as opposed to me doing positive pressure with them, then risk versus benefit will now come into action. I don't know if that makes sense. Hello, Ma?
Yes, sir.
I don't know. So sometimes you can have
The positive pressure. The positive pressure you're talking about is
the positive pressure can be cough assist, it can be IPPB, it can be MHI. If this patient is connected to ventilator or anything, we can even do VHI with them on the bench. So, but if we now link into what we've got back home now, for instance, now, it could be now me looking at, okay, maybe if I ask them to do deep breathing, maybe I can also mark their abdomen if they can tolerate it. Not everybody can tolerate it. Don't forget the secretion is on the other side. And again, when it comes to this thing we used to do, bad lungs up, do you want to put the bad lungs, the affected lung, this right lung, do you want to put it up? You will also impact, you will also the drainage from everything from the knee surgery, the operated surgery can also impact the good lungs. So that might also be limited with that. So it could just be you going there. Yeah, maybe if they are slumping bed, get them upright in bed. Maybe if you cannot even put the operated lung down because of pain. But usually you find this patient in that position. The operated lung will be down, like will be the, what do you call it now? Will be the dependent lung. Okay. So
how do you position the patient? So how do you now position? If the affected one is up, it will impact on the unaffected one. So how do you now position the patient?
So now, the positioning now is you can get them upright. If they are not restricted, like keep them, because sometimes you might read, they might say for one day or this thing, keep them in right side line or something. If they are not under any restriction or anything, it could maybe, for instance, let's say I just go to that, but they are slumping bed, I just get them upright. But I cannot do that bad lungs of day one surgery. I'll still be doing something to drain it.
Okay, maybe facing up, semi-fowler, facing up.
Semi-fowler position, upright, semi-fowler position. So I can still do my ACBT kind of things, but remember, somebody have got right-sided, all the right side of the lungs have gone. So remember how they are likely to be presenting. Remember, they are going higher from 60 now, they are going to 80. So we might also need to do top to bottom in our treatment. We might also need to do top to bottom. So the whole essence of all of these things is, so our toolbox, a lot of things are still missing. In our acute hospitals, a lot of things are still missing. In our skill set wise, a lot of things are still not there. So we need to keep training ourselves, keep having all of these clinical discussions, some words that we are still not going there to be doing stuff. We also need to be going there and be doing stuff with those patients. Yeah, like ENT is one of them. All this renal word, we'll still, maybe in the future, we'll still have stuff on renal physio. There should be physio, medicine physio that can look at blood. Renal is purely medical. Blood, potassium, urea, creatinine, you have to be good with those things. And when do I have to do this? Is it before dialysis, after dialysis? Because after they do their dialysis, they'll be fatigued, they'll be doing all these things. All these things, we need to know. Physio need to know this thing and target your physios appropriately. We still have to know. So let's just keep doing whatever, as much as we can, and getting everybody, because like I keep saying, acute should be separated from outpatient. I'll keep saying it. I know a lot of people will disagree, but and again, it's going to be like a kind of, it's going to create a lot of employment. I know we are struggling. We have a lot of issues. Nigeria and generally, we have a lot of issues, but still, is something we need to be looking forward to do. Like, it has just have to be separated. It's just different skill sets entirely. Different way of reasoning patient entirely. Different way of seeing patient entirely. So that is just it. I hope we have made we've been able to make a lot of values from today's sessions. Any question? Anything we like to ask, or any area we like to have further trainings, like you like us to come up with further trainings or anything before we close the meeting?
So just like he said, the pediatrics, X-ray, and pediatrics, how to read the X-ray.
Yeah.
Although they are very, very important.
Yeah. Yeah. Thank you very much. Yeah, I'm gonna come up with that. Yeah. Unfortunately, it was part of the initial plan, but unfortunately, couldn't do that. But yeah, I'm gonna come up with that by God's grace. We're gonna have discussion on that. Yeah. Let me read the chat box.
Mechanical ventilator.
Yeah, mechanical ventilator. What is the let's just break it down for ourselves. Yeah, and yeah, for that mechanical ventilator as well, I also appreciate if we can put it because they have different brand of ventilators, and it can even vary from setting to setting. I also appreciate if we can maybe pop in the chat box or something on the page, like different ventilator, the kind of ventilator that we got in our facility. Even though because ventilator, one problem with ventilator, it could be different ventilator with different name, different name, same thing or something. So I would just appreciate if we can copy the kind of model of ventilator that we have got in our. But I'm going to come up with general concepts about ventilator. When you are looking at the screen, the weight, the parameter they set on the ventilator, are getting in the tube or in the chest of the patient, all those kind of things. Volume control. I'm going to talk about it by the case of God. They are not really talk about it. Or any other area in acute care, and again in the future, I also like to come about like research. Let's just look at all right, thank you very much. Thank you very much, everyone. Thank you for joining. Thank you for making these things a success. Hopefully, we'll catch up.
Your phone number. Your phone number, sir.
My phone number. Okay, I'll put it on the page by God's grace. I'll put it on the page.
Okay, sir. Thank you, sir. Thank you, sir, for your time and everything, all the efforts to put us through. God bless you, sir.
Amen. Thank you very much. Thanks for your kind words.
Thank you so much, sir.
All right, you're welcome. Thank
you. Thank you, sir. I appreciate.
All right, sir. All right, sir. Thank you. Thank you. I appreciate everyone. Thank you for joining.
Thank you, sir.
Thanks a lot.
Thank you very much, sir.
Yeah, right. Thanks a lot. We'll catch up next time by the grace of God. All right. Bye-bye.
Bye-bye. Fine. Where is Esther? Where is Esther? You go and Esther for me. No, that's our money. Go see Esther here. Where is Esther? This is mommy. Where is Esther? Go your Esther.
Nathan Mary.
Ọjà síbi kan wá lo àwọn oògùn yìí o, madam. O gbọ́ àbó gbọ́. Ọmọ ibi tó ń fi ọmọ odó yìí sí o. Tó gbẹ̀jẹ̀ tí mo sì rà sílé ìgbà mi tí mo ẹni tó wá gbé owó tó wọ expiring date nǹkan tó lọ rà wọ̀nyí. Ó kàn lọ rà ó ṣe kún owó expiring date ẹ̀. Lọ ṣọtí nù. Gbà lọ́wọ́ mi. Authentic tó kù lẹ́ẹ̀kan yẹn. Inside with. Inside that place oògùn ló fi síjà kí n fi kọlà sí ẹ lọ́pọlọ nísìnyí nǹkan. Sọ̀rọ̀ ẹ̀ tà lélẹ̀. Ṣe máa ń gbogbo kúrò ní ìṣẹ́ náà. Ó lè wá lọ gbé wọn síbẹ̀. Tó bá ti jẹun kí
Sabi, so I remember I checked specifically trying to remember I checked because I was looking, I said, let me know if there's any meat. I didn't see any this thing here. No. Everything. I checked this out. Oh, this afternoon gone. I check it. See, okay, no any this thing. Eh?